Hi, my name is Jenna. I'm going to present to you today regarding atrial fibrillation. So to start off with, my patient was a 72-year-old gentleman who presented early morning for his colonoscopy with the surgery department. All patients who present to the surgery department are placed on telemetry prior to entering the OR. During his procedure, they found a new finding of atrial fibrillation via the telemetry monitor. After his procedure, his primary care doctor was called and notified and were unable to see him in the clinic. Therefore, they brought him over to the emergency department for evaluation and treatment. Upon emergency arrival, patient's vitals were taken. Pulse was 68 and regular. Blood pressure was 138/92 and respirations were 16. Patient presented normal with no signs or symptoms of distress. We placed him back on the telemetry monitor and his heart rate did get up to 186. ER physician came in to see him and treatment was discussed with him versus medications and the cardioversion, which I will get into furthermore. So during EKG, it was found to be irregular. There was no P waves, and those are two top things in atrial fibrillation. So atrial fibrillation, the pathophysiology. Atrial fibrillation is a cardiac dysrhythmia characterized by a total disorganization of atrial electricity activity without effective atrial contraction. Etiology. Atrial fibrillation is caused by a malfunction in the conduction of electricity in the upper chambers of atria of the heart. So in people with AFib, the electrical signals that control the heartbeat are abnormal. The top two chambers, which are your atria of the heart, stop pumping blood as strongly as normal. So here in my picture, so we have your atria here on top. So the atria start to quiver and give off that weird kind of heartbeat, and it's really fast. So in some people, AFib never goes away. In others, AFib can come and go even with treatment. So some manifestations of AFib: a feeling that your heart is beating rapidly or irregularly, a feeling of discomfort or pain in your chest, shortness of breath, sudden lightheadedness or weakness, and getting tired easily during exercise. So when my patient came to me that day, he had no signs or symptoms of AFib whatsoever. He was actually very confused as to why he was in the emergency room with us. So kind of once we hooked him up, that heartbeat did spike, and then he kind of was saying how during activity or noticing kind of more at home, he was becoming fatigued, and that's probably more than likely why. So he could have had AFib for a long period of time and never knew it. So some risk factors of AFib: older adults, people who smoke, diabetics, people who are overweight, and athletes who exercise vigorously, and people who have a family history of AFib. And some complications of atrial fibrillation are blood clots, stroke, heart failure, heart attack, cognitive issues like dementia, and sudden cardiac arrest. So with stroke, AFib can lead to stroke. That is a huge thing. So like in this picture, he has AFib in the left atria, and then the clot forms, and then in the heart, it strikes up into the aorta, and then the clot enters the bloodstream and travels toward the brain through the carotid artery, and then the embolus blocks blood flow to part of the brain, and then stroke occurs. So some diagnostics of atrial fibrillation: the first thing is an EKG. So that is what we did that day with that patient, and that is just informing the patient that he does have that irregular heartbeat going on. And then he actually went back into normal sinus rhythm a couple times, where his heartbeat would drop within that 60 to 100 range, and then again he would kind of spike back up. Some other diagnostics you can do are that 24-hour Holter monitor. So that's where the patient will go home with electrodes on their chest and just kind of hooked up to that monitor again to see how often they go into that AFib. So to tell patient, very important, take shower prior to coming in for that Holter placement, because when they go home, they cannot get that monitor wet or anything like that. Avoid any activities that would lead to the Holter monitor getting wet, and then kind of tell them not to change their activity. We want to see what really would lead to the AFib to occur. So if they don't walk 2 miles, tell the patient not to go home and walk 2 miles. Stress test is another thing that we can do. You want to inform the patient to wear comfortable clothing and shoes when coming to the stress test. Beta blockers should be held 24 hours prior to testing because they blunt the heart rate and limit the patient's ability to achieve a maximum heart rate. Caffeine-containing food and fluids are held for 24 hours and monitor the patient during the test with a 12-lead EKG. And then another testing that we can do is the transthoracic echocardiogram, and that evaluates how blood flows through the heart. There's no special preparations that the patient needs to follow prior to doing this exam. Patient can eat and drink and take all medications as normally as they would at home. And then if they came in for a transesophageal echocardiogram, a probe with an ultrasound transducer tip is swallowed while the physician controls the angle and depth. As it passes down the esophagus, it sends back clear images of the heart size, wall motion, and valve abnormalities. Patient needs to fast at least 6 hours prior to examination, so nothing to eat or drink by mouth. If they have dentures, they will need to remove them. And during exam, IV sedation is given and throat localized anesthetic also. A bite block is placed in the mouth. You want to monitor the vital signs, oxygen saturation levels, and perform suctioning as needed during the exam. After the exam, patient may not eat or drink until the gag reflex returns. Sore throat is expected and is temporary. A driver is also needed to take the patient home from the testing center. Other exams that we can do is a CT scan, chest x-ray, and some lab tests. For lab, there is no really anything specific for AFib, but blood testing can be done to rule out other conditions. So they can do a CBC, troponins, CK, and BNP to check for any other heart injuries. I'm just gonna move this. And then if you want to come close. So this is an EKG sample. So here this patient was an AFib, dropped kind of back to a normal sinus rhythm here. So again, no P waves, it's very irregular. So those are your two indications that he's an AFib. A nursing diagnosis for this patient is decreased cardiac output related to alterations in the rate, rhythm, and electrical conduction as evidenced by increased rate on exam and EKG changes. So some collaborative care that we can do for this patient, we can do medications which are used to help decrease the heart rate. So like some examples would be calcium channel blockers, diltiazem, beta blockers would be metoprolol, and then you can also do digoxin. Electrical cardioversion, which we did with our patient that day in the emergency room, that just converts the heart back to the normal sinus rhythm. And then we can also do anticoagulation therapy, which is that warfarin, and then Eliquis or Xarelto, which that some patients will take long term. And then also a Maze procedure, which is a surgical intervention that stops atrial fibrillation by interrupting the ectopic foci that are responsible for the dysrhythmia. And then some goals and outcomes for my patient. So the first goal that I have is restoring the normal heart rate rhythm by resetting the heart or controlling the heart rate. Some outcomes that we want to do, patient will maintain normal vital signs and normal sinus rhythm while being on the telemetry. A second goal for my patient, patient will participate in activities that reduce cardiac workload, such as maintaining weight, eating a heart-healthy diet, and tracking daily fluid intake, managing stress, and avoiding and limiting caffeine products. So an outcome, patient will be able to choose foods from the DASH diet, which are rich in fruits, vegetables, whole grains, and low-fat dairy, and participate in cardiac rehab. So some nursing interventions. For the first goal, we want to listen to that apical pulse, assess the heart rate and rhythm, and inspect the skin color, palpate peripheral pulses, monitor the urinary output, monitoring for any decreased output, and concentrated urine. Some goals for the second one, we want to inspect fluid balance and weight gain. We want to weigh patient regularly each morning and try to get them in the same clothes each day to really see that weight change. We want to assess the oxygen with pulse ox at rest and during activity. So if they are in cardiac rehab, we want to have them on that monitor. And then checking for symptoms of chest pain during activity. So any shortness of breath, dizziness, if they are experiencing that, you want to sit them down right away. And then assess for reports of fatigue and reduced activity intolerance. So when that patient was in the ER that day, we actually cardioverted. So the ER physician, he goes right to cardioversion. He does not go through the medication process. So the patient was very concerned that day. What is the difference between medications versus doing the cardioversion right away? So with the cardioversion, we hooked him up to an IV, gave him fluids, and then gave him some medication to kind of put him back to sleep. And then the physician came in, we put some pads on, we did one on the anterior and posterior, and then he was on the EKG that whole time. And then we did the electricity to the heart. So when the doctor was ready, we were all set, we all stayed back. And then the physician had hit the button and it cardioverted him. So we only had to do it once and the patient was back into normal sinus rhythm. So it actually took us longer to hook him up versus doing the procedure. So I do have a video here that I want to show how the cardioversion occurs. Real short video.
And pushing false narratives. Well, take a look at this.
Look at that.
Over the last 3 years,
atrial fibrillation is the most common type of cardiac arrhythmia. In a healthy heart, the sinoatrial node, or SA node, initiates all electrical impulses in the atria. In atrial fibrillation, electrical impulses are initiated randomly from many other sites called ectopic sites in and around the atria, commonly near the roots of the pulmonary veins. These unsynchronized, chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. Although the atrial rate during atrial fibrillation can be extremely high, most of the electrical impulses do not pass through the atrioventricular, the AV node, to the ventricles. This is due to refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate or heart rate is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. Reminder: P wave represents electrical activity of the SA node that is now obscured by activities of multiple ectopic sites. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. As the atria do not function properly, the heart puts out less blood and heart failure may occur. The most common complication of atrial fibrillation, however, is the formation of blood clots in the atria. As the atria do not empty completely into the ventricles, the blood may stagnate inside the atria and blood clots may form. These clots may then pass into the bloodstream, get stuck in small arteries, and block them. When a blood clot blocks an artery in the brain, a stroke may result.
And then just have a second video, and here's the
You must
cardioversion.
avoid eating if you have arthritis. If you have arthritis,
If you have an abnormal heart rhythm, your doctor may perform electrical cardioversion, where he or she uses an electrical shock to restore your normal heartbeat. The heart normally beats in a regular rhythm at 60 to 100 beats per minute. This steady and coordinated rhythm allows the heart to effectively pump blood. Electrical signals that travel through the heart control the heart's rhythm. These electrical signals start in a cluster of cells called the sinoatrial node, or pacemaker. The sinoatrial node, or SA node, is located in the wall of the right upper chamber of the heart, called the right atrium. When the electrical signals reach the heart muscle, they cause it to contract and pump blood. An abnormal heart rhythm is called an arrhythmia. During atrial fibrillation, the atria quiver because of chaotic electrical signals in the heart, resulting in an abnormally fast or irregular heartbeat. Because of the abnormal heartbeat, blood may pool in the atria, which can result in the formation of a blood clot. If the blood clot passes into the general circulation, it may cause a stroke. Before the procedure, you will be connected to an intravenous line. You will be sedated so you will sleep through the procedure. EKG electrodes will be placed on your chest to monitor your heart's electrical activity. Once you are sedated, special cardioversion pads or paddles will be placed on the skin of your chest or your chest and back. These pads or paddles will deliver electrical shock through your chest to your heart. The shock may be repeated several times until the heart resumes its normal rhythm. After your electrical cardioversion, you will be monitored closely in a recovery room or in the coronary care unit of the hospital. Once the sedation wears off and you are in stable condition, you will be sent home.
Okay, so oftentimes many people think, can they live a normal life with atrial fibrillation? And the answer is yes. Do your normal activities. Obviously, you just want to maintain that healthy lifestyle, dieting, maintaining that blood pressure by eating those healthy foods, following the DASH diet, and taking those medications as directed. Some other things, if a patient came into the hospital like mine, he was lucky enough, he did go home that day and followed up with primary care doctor the following day. But if they were in the hospital, we would obviously want to start an IV, whether that's with heparin, and then work our way to that Coumadin, and then having them follow up with primary care. Monitoring labs like the electrolytes, so sodium, potassium, creatinine are very important. Obviously, if you have a high potassium, you're more at risk for cardiac dysrhythmias. And then just monitoring that patient for those symptoms, shortness of breath, dizziness, take those all into consideration when they present to the emergency room. And then that is all I have for you. Thank you.